Hello and welcome to another edition of the Osteopathic Lyceum podcast. Going to go through an article from the Journal of Osteopathic Medicine. This one it was published on February 14th of 2022. The title is Effects of Osteopathic Manipulative Treatment versus Osteopathic Cranial Manipulative Medicine on Parkinsonian Gait. Okay, so there's going to be two different treatment interventions, and the aim or the measured outcome is a change in gait for those with Parkinson's. They do a pretty good job of comparing this against what would be considered a healthy control or a control who receives the same intervention that does not have Parkinson's. And I'm going to get into the paper a little bit. I'm going to try to be pointed and not too long-winded with reading. If I end up doing that, I do apologize in advance if it bothers you, but I'm going to try to be on point because there's really one main thing that leaves me with questions. So they do notice that what they call the OMT-WB or the OMT whole body approach, which includes cranial intervention or cranial assessment and application of technique, has a statistically significant difference with respect to hip mobility within the patients with Parkinson's versus what they call the OMT neck down or ND protocol. So there's some difference here that is notable between groups. The big takeaway is that it doesn't seem to do anything to the actual Parkinsonian gait, which is likely unfortunate because one would hope that if you have an intervention, it would have a positive impact on the outcome goal or the outcome measurement. And at least from what I remember, it does not. So I'll read a little bit from the start because it does give you a decent rationale as to why they wanted to check this out. To read, a reduction of joint range of motion ROM in the sagittal plane is a prevailing feature of Parkinsonian gait and fall risk. Gait analysis has found that people with PD or Parkinson's disease have a significantly slower walking velocity, decreased stride length, and decrease in range of motion at the ankle, knee, and hip joints compared to controls. Well cited. The gait deficits identified in individuals with PD, Parkinson's disease, have a significant role in increasing fall risk. A reduction of maximal hip extension in the terminal stance phase and a reduction in plantar flexion of the ankle at toe off reflects a more conservative gait pattern with less propulsive drive, which would contribute to the slower walking velocity and step length seen in Parkinson's disease. A slower walking velocity and decreased step length have been associated with increased fall risk in elderly populations, yet they are not the only indicators for increased fall risk in individuals with Parkinson's disease. Sufficient vertical foot clearance may not be maintained in Parkinsonian gait, so they don't lift their feet high enough. To read again, due in part to a decreased range of motion of the knee joint. This can have important implications for walking on irregular surfaces or obstacle avoidance, because insufficient foot clearance can result in a trip and subsequent fall. In individuals with Parkinson's disease, increasing the functional mobility of the lower limb joints by increasing range of motion could reduce fall risk and increase walking velocity. My superficial question to start would be whether or not the decreased range of motion is when walking or when being assessed, because somebody could possibly have good range of motion when actively or passively assessed in isolation, but maybe not utilize that as a motor pattern for a variety of reasons. So that's a superficial question, possibly a deep question, but one that would be useful to answer so that we could understand whether or not we would predict any value in targeting these things. So don't need to go through the rest of the background with respect to what these authors wrote. I think they did a pretty good job. But yeah, if I was involved in the project, my initial question of the literature that pre-existed would be, how did they figure this out with respect to range of motion? Was it when walking, or was it when passively assessing or actively assessing these subcomponent parts in the sagittal plane out of context? Like, are you assessing just those things, or are you only assessing the walking gait? I would assume there's a variety of assessments based on what I would hope would be in the pre-existing literature. Anyways, I'm going to read the methods here. The study was approved by the North Texas Regional Institutional Review Board, which matters. The study was funded by a grant from the American Osteopathic Association. The study was post hoc registered with clinicaltrials.gov. So they were doing a great job of telling you how they got review, where they got money, and what they did after the fact, the post hoc. Prior to the study, written and informed consent was obtained from all participants by the authors RMP and KLH. Participants were compensated $50 each for a one-time visit if a participant arrived in good faith for testing but was disqualified by the investigator. Scores of less than 26 for PD group and less than 24 for control group on the MMSE or greater than 3.0 on the Hoehn, Hoehn, and Yahr scale, which is for Parkinson's disease. He or she was paid $10 for their participation. So they're just noting that there was monetary compensation. Some people will be fine with that. Other people will find a way to have a problem with that. But they're being clear, and that matters. I'm not going to read the inclusion-exclusion criteria. I'm not going to do that. Study design and data collection. I'll read this. Data were collected utilizing an 18-camera motion analysis system, Motion Analysis Corp., Santa Rosa, California. It matters that they tell you not only what they did, but where they got the equipment, because your ability to reproduce is incumbent upon your ability to use the same equipment. Integrated with a dual belt treadmill, V-Gate Computed Assisted Rehabilitation Environment Network, CARENDIH Technology Incorporated, Norwell, MA. So I'm assuming that's Massachusetts. Sampled at 120 hertz and 1200 hertz respectively. A chest harness tethered overhead to a steel safety system could support the participant's entire body weight in the event of a fall. And they have a picture of that. So these, especially with respect to those who did have Parkinson's, it's important to provide safety. One of the things within research is that if you're going to utilize any living thing, you want to make proper accommodations for safety. You want to get past non-maleficence, first do no harm, and then you want to get to beneficence. Now, it is possible to get ethical approval for something that will cause harm under very, very strict circumstances, but generally speaking, most research is going to be performed and approved based on getting past first do no harm. To continue to read, after consenting, participants drew a letter from a basket to identify randomization into one of the three treatment groups, 15 letters each. The study design included a sham standardized OMT neck down, which is OMT-ND, and standardized OMT whole body, including OCMM, OMT WB protocols. After written informed consent was obtained, participants underwent a baseline assessment of clinical measures and neurological evaluations using the mini mental state exam, the UPDRS, and Hoehn and Yahr stage H and Y. Each participant's natural walking speed was then calculated by timing a short walk over 20 feet over ground distance and was utilized to set the initial treadmill speed. Participants then donned a harness, had 54 markers placed on key anatomical landmarks based on a modified Helen Hayes full-body marker set, and underwent a short static and dynamic calibration phase for the motion capture system before completing a variety of tasks. The study examined the walking task only. During the walking task, the treadmill was set at the participant's natural walking speed and adjusted to match the participant's comfortable habitual walking pace. Once adjusted, the participant walked for 30 seconds at this pace. So they were quite reasonable in trying to ensure that they checked things before they matched on the treadmill. One of the challenges with treadmill walking simply is that there is no propulsion force essentially going forward. So especially if it's a forward walking gait, there is a portion of that can be taken out because the treadmill can, at higher contact, ground contact times, pull the foot backwards. So there is some variance, but it is very important to note that if you have everybody doing the same thing, you can extrapolate from everybody doing the same thing. So it would be more ideal if you could do this walking across ground so the person was propelling themselves forward. It would be better, but if everybody's doing the same thing, then your ability to extrapolate data about differences between groups is good because they were all subjected to the same protocol. So that's one of the defensible things that you would do. It's also really, really hard to, and probably much more expensive to have setups where you could measure things with people walking over ground, or maybe I'm wrong and there's camera systems that will do the trick. So I actually don't know, but there's things worth considering here. Yeah. Okay, so I'm going to continue to read here. After the baseline assessment, participants received an OMT or sham treatment protocol from a board-certified neuromusculoskeletal medicine and osteopathic manipulative medicine osteopathic physician, which was not the authors, one of the authors, KLH and RS. Maybe it's both authors. Following our brief descriptions of the OMT, ND, OMT, WB, and sham protocols. So before I read this, I'm going to say that I don't know if there was an editorial decision made to remove some detail or if more detail was not provided, but this is the exact place where I have questions about any of the findings from this. So I'm going to read OMT-ND. The neck down protocol took into consideration previous relevant studies. OMT was utilized bilaterally on the following areas with one or more techniques, including myofascial release, articulatory, muscle energy, and balanced ligamentous tension. The OMT-ND protocol lasted approximately 20 to 25 minutes and targeted cervical, thoracic, and lumbar spine, shoulder girdle, sacral, iliac joint, and nominate leg musculature, including psoas, piriformis, hamstring, and adductors, and ankles. What I want to know is if they did something to every one of those areas, regardless of what was found bilaterally, if they did something to what was found based on identification of restriction, it says they used one or more techniques, which included MFR or myofascial release, articulatory muscle energy, and balanced ligamentous tension. So I want to know if somebody got all of them, if everybody got all of them, if some people got one, some people got two, some people got three. What was the criteria for cessation of treatment to a region? Because I would want to know how they found problems or if they cared if they found problems. Like I need more information on this to be able to judge my confidence level in what the outcomes are. So to continue to read, OMT-WB. This protocol included all of the techniques in the OMT-ND protocol, but it also included techniques focused on expected cranial dysfunction. The OMT-WB protocol lasted approximately 25 to 30 minutes and included the following: evaluation for strain patterns, occipital-atlantal decompression, sphenobasilar synchondrosis, decompression, occipitomastoid, suture V-spread, temporal bone balancing, and venous signage drainage techniques. So again, I want to know, did they do all of these to everybody plus all of the other stuff to everybody? Like, I need more detail on this because what I'm sensing from this, or what I'm observing, suggests that there was some uneven treatment between individuals, which makes it harder to interpret the results, because when you've got uneven application, things get more complex. There are more things playing off of one another because you controlled for less. So I would like to know. It doesn't mean that what they found is not correct. It just means that I need more information to have confidence that it's correct. To continue reading sham, the sham protocol consisted of an examination of the subject's active and passive range of motion in the spine and extremities, and tested the same joints that were treated with OMT. The subject was similarly positioned in sitting, supine, and lateral recumbent positions, but did not receive active intervention. To provide a sham for the OMT WB or whole body protocol, the subject lied supine with the physician's pronated hand supporting the dorsal aspect of the patient's head. The sham procedures were conducted for approximately 20 to 25 minutes. So there's an obvious difference in time indexing. That time indexing is an uncontrolled variable. So the 20 to 25 for the sham and the ND, or the neck down, versus the 25 to 30 minutes for the whole body, which includes cranial, there's a variance in time indexing, and I would be interested if that did something. It doesn't mean that it did, but I would be interested in chasing that down a little bit more. The lack of clarity with evenness of intervention is of interest, because it is possible, at least with the lack of information that I have here, that the OMT-WB, or the whole body approach, might have done more to the lower extremity than in the OMT-ND, and not necessarily recorded, reported, or observed it. That would be something that would explain some differences that we end up seeing. I just need more information. I can't throw this out the window, but I also can't pin it on a wall, right? I wouldn't hold this up as ideal because I'm unfortunately missing information. So it goes through the data analysis or data processing, which we don't need to do, statistical analysis, which we don't need to do, participant demographics. I don't need demographics. The results, yeah. So a few people, they couldn't unfortunately grab the data properly because the markers ended up in places that generated unusable data. Don't need to necessarily get crazy about that, but they're very clear about it. So they're very diligent, which is wonderful. The diligence in reporting variance is good for standard things. It's just I'd really like to see more with respect to the actual hands-on treatment. Yeah. So I'm going to read this portion. Comparison of Parkinson's disease pre-treatment and post-treatment joint range of motion revealed a significant increase in hip range of motion following administration of the OMT whole body protocol. No significant differences in hip range of motion were found after the OMT ND or sham protocols, and no significant differences were found at the knee or ankle joint for any treatment group. In healthy controls, no significant differences were found in joint ROM. No significant differences were found in the hip, knee, or ankle joint waveforms following OMT whole body, OMT neck down, or sham treatment protocols in Parkinson's disease or controls. So essentially what they're saying is the only thing they found any difference in is the OMT whole body in the hip. They did not find a meaningful difference in the OMT neck down, only the hip. Only the whole body and only in the hip. Everything else, there was really no difference regardless of what happened. So what that would do, if you had a hypothesis, it would support the hypothesis, or really would generate the hypothesis, is a better way to say it, that cranial treatment would actively improve the hip range of motion in Parkinson's patients. The way that you would figure this out is you would have sham versus cranial only, and see what the heck happens with respect to the hip range of motion. Because the primary difference, as far as I can tell, or as far as what is written, is that when actually treating the hips, it didn't seem to change the range of motion of the hips, but when treating the hips and the head, it seemed to change the range of motion of the hips, which would suggest that it's actually the intervention of treating the head that changed the hips. And we could track this down. This could be done. It's an interesting finding. It's one that would deserve more testing. And that's the thing that I'm taking away from this. But because I'm missing so much information about whether or not treatment was applied evenly to the region of the hips between these groups, I just don't know. So I can't actually interpret this. This would lead to another experiment, so that if that experiment lined up with what was found here with respect to treating the head, changing the hips, then I could buy this. So I could just do it as a side thing. I wouldn't need all of the fancy stuff. I could just treat the head the same way they treated the head, measure the hips the same way they measured the hip, and look for difference. But I would need people with Parkinson's specifically. And I could, I could just do that as a side experiment. I wouldn't absolutely have to rerun a control group with age-matched healthy controls. I could do that. It would probably be the more valuable way to do it. But to buy anything that they say, I have to test the hypothesis that is now generated that cranial treatment is the difference for Parkinson's patients with only hip range of motion. So it really narrows it down and allows me to figure it out or be more targeted in subsequent experimentation, or the desire for subsequent experimentation. Essentially, excuse me, in the main measure, whether or not there was change in the gait, there's really no change in the gait if I remember right. I'm actually going to roll way back up to the abstract, because it'll be quicker here. Does it? Yeah, so just to read from the results in the abstract, Individuals with Parkinson's disease had significantly reduced hip and knee extension in the stance phase compared to controls. Individuals with Parkinson's disease experienced a significant increase in total sagittal hip ranges of motion following a single session of the standardized OMT whole body treatment protocol. However, waveform analysis found no significant differences in sagittal hip, knee, or ankle angles at individual points of the gait cycle following OMT whole body, OMT neck down, or sham treatment protocols. Okay, so the isolated hip testing in those patients with Parkinson's showed change with respect to the post-treatment measurement of the cranial and whole body approach, not just the neck down approach. But when they actually tested the gait, there was no change. So if we consider the thing that I was talking about before, the testing of joint angle or joint range of motion in isolation, whether it's patient active or patient passive, because I'm not clear on that based on what's written, and some of that could be editorial choice, so how many words they had to write it. So some things are missing that were done and would be more clear if there were more words. But you can change the ranges of motion in isolation or when assessed as something that's not within gait, and have no meaningful change in gait because the gait is more about motor control and likely planning of motor control. So previous experience, fear, balance, so sensory feedback mechanisms. There's a lot of stuff that could be going on, which would be why you don't see any change in the gait cycle, but you see a change in at least the hips with at least one of the treatment interventions, which we would need to understand more. But it does not seem valuable to chase this down further for the measurement of gait. Right? So you can improve a measurement on the person and not improve your primary outcome. That is an important thing to understand. When you assume that changing range of motion in a particular place in a particular way is going to change another behavior or another thing that you could test, you may be wrong. The easiest thing for me clinically to share with you that has value is the neck. The neck is way easier to treat in supine, but it is more impactful for the person when they are upright, right? So the comparison would be you test the neck in seated, and there will be a certain amount of sensation and movement and tension or tone that will be apparent in muscles. When you put them in supine, it will behave differently because it's a different set of circumstances and the tests are different. You can make good change in the tests that you apply in supine, and when the person comes back up to seated, they still feel the same thing, even if they're moving farther, because they're two different contexts and different tests and different levels of sensation. So clinically, you can do a fantastic job in the neck and supine, and the person is going to have the exact same problem in the other context of seated. So then it would be incumbent upon you to try to do more of that work back in context and seated to see if you can make a change to at least the movement and the sensation. So the movement for sure, but the sensation in seated, because I've experienced many times you do a really good job with the neck. It changes a lot in supine, and it doesn't change much in seated because it's a different thing. It's a different context. So having the fundamental assumption that I can change something in one context and have it mean the same thing in another context is not consistent. It's a challenge. So I'm not surprised that they don't find much of a difference in the gait cycle when the hip changes. I'm definitely not surprised that they don't see anything in the gait cycle because the knee, the ankle, and everything else don't really change their sagittal mechanic with the treatment, regardless of the treatment. But the hip does, and there's no change in the gait cycle when the hip does change. Because they may not be having large range of motion issues with the knee or the ankle. They may have had large issues or notable issues with the range of motion in the hip, but it didn't mean anything to the gait cycle because the gait cycle is determined by different things that are not necessarily predicted by range of motion. So you can have full free range of motion and not use it as a movement solution. The more important thing here is context. you can find something in one context, change it in that context in relation to the test that you performed, and it will not impact another context, because that other context is governed, maybe the wrong word, but maybe controlled, maybe impacted, influenced by another set of factors that are not going to be impacted by the intervention in the other context. So it is important that you have the ability to understand construct, or that thing which has definable boundaries and can be utilized to describe a thing of its own merits. So if I were to show you two things that had, I'm going to try this. Give me just a moment. I'm going to sneak away from the camera for a second and hopefully not hit anything. So if I hold this up, there are two, and for those listening, you may or may not see this, there are two rectangular objects on the screen. So if I just use the construct of shape, they are both rectangular. If I use the concept of color, at least for the purpose of this, we could call them both black, right? So one is a phone and one is a microphone case, but they're both black rectangles. So I have the construct of color and the construct of shape, and they are the same, but we know they're different. Now I need another construct or another category to describe it. I could do it based on purpose, and the purpose would immediately make it apparent. But some people may not be able to intuit the purpose if they didn't know enough about the objects. But I could ask, does one of them have a closure device? And one of them does have a closure device that's apparent, and that's the zipper on the microphone bag. Right, so we need more categories to try to start to understand this stuff a little bit better. But if I'm just measuring on one category, and that's range of motion, and I'm expecting it to change another category, well, I have to measure that category and figure out what that other category is and what would predict change in it. And that other category is gait cycle. So at least for now, with one isolated change in range of motion, for those with Parkinson's, we don't see a change in gait cycle. So we could either keep banging on and trying to make sure that we change the other ranges of motion. We could chase down if cranial treatment consistently in the way that it was applied changes hip range of motion in patients with Parkinson's disease, because that's interesting. We could say, I think one of the things that we're learning is that trying to change something outside of context may be harder than we think, because we can take it out of context and change it, and then it's possible that when we put it back in to another context, the outcome measure may not change much. So that's worth tracking down. It's worth experimenting with. It's worth seeing if there is other stuff that's already described this, so that we could go towards what's called consilience, or to describe that properly, sources of evidence from different modes of investigation that point at the same thing or point at the same phenomenon. If that's already there, then we could actually try to see if that's consistent, because we could develop a construct with respect to changes of range in motion and other outcome measures. Something from my own personal past with respect to my preferred form of exercise in sprinting, increased range of motion in the sprinting mechanic may not predict faster times. In fact, sometimes it may predict slower times, because going farther through a range would decrease frequency of stride or frequency of foot contact, which may mean that the total time spent throughout the run increases rather, because you're moving too far, you're dropping the frequency so that you're not creating the propulsive impulse at the right amount of frequency to get down the track. So by increasing range, you may decrease decrease speed and increase running time. For somebody who's really tight, maybe it'll work, but the context is going to have some important things here. The idea of a high knee, quote unquote, above and beyond the knee getting to the furthest point away from the torso, and say starting to get higher with relation to the ground, so higher, the knee getting higher off the ground beyond the knee getting to the furthest point away from the torso means that the knee is starting to come back towards the individual, which means that it's got to travel farther towards the ground before ground contact, and that's going to change the mechanic. So lots of fancy words to say that increased range of motion may not improve sprinting time, right? One would think it would, because increased range means I have more ability to get to certain positions. It doesn't necessarily follow. So the context of measurement may matter just as much, because the thing that you're measuring may be governed by things that are not what you're going to measure in another context and change. The clinical thing that I already talked about is you find a problem in the neck, the person complains about it when they're seated, you put them in supine, you do a great job with the neck, it changes nicely, you put them back into seated, and it hasn't changed in seated. It changed in supine, but it didn't change in seated. So it's a different context. It's a different set of tests. It's a different thing. Even though it's still the neck, it's still in that person, and it's still within a relatively close time frame, and it's after I made observable changes in supine. So understanding what a construct is, understanding that change would better be provided within the construct as opposed to found in one construct and changed in another one. There are definitely times where you can make change in something in a different context, and it will apply back to the initial context. It does happen. Clinically, one of the easiest ways for me to describe this is I will find vertebral restriction with a seated patient who actively moves their vertebral column in a variety of planes of motion. I put them into prone and I treat their vertebral column primarily by interfacing with the erector mass or the postural muscles or the vertebral muscles, whatever term you like. I put them back into seated, and I will note consistently a change in the active vertebral range of motion. So I've found it in one context, treated it in another, put it back into the initial context, and it does change. But for some reason, this doesn't apply to the neck consistently. So I think the experiment was well done. I think the writers did a pretty damn good job of being explicit with all of their choices. They followed all the rules. They did great. I am concerned that there may have been uneven treatment applied, especially within the region of the hips with the neck down protocol versus the whole body protocol. So I would want to see further experimentation of the Parkinson's patients being just treated within the cranium the way that these experimenters did, and to see if that consistently changes the hip range of motion. If it does not, then it's the interaction between the two. So there is a hypothesis generated from that, but it doesn't seem that gait cycle is the proper context to change by attempting to change range of motion within the Parkinson's patient. So that suggests that the gait cycle of the Parkinson's patient is governed by something else other than range of motion. They are likely altering their range of motion, even if they have more available to them, due to a variety of factors. So overall, I like the experiment. I think there's a lot of value. I think there's some things that can be gleaned and tracked down further. I'm not satisfied with the description of the methods because I can't tell what was done within the neck down protocol that is the same or different with respect to everything other than the cranial approach when considering the OMT whole body approach. But overall, pretty good experiment, gives me some interesting stuff to consider and would give other people something worth tracking down in a varying way. But keep in mind that I think the primary lesson here is some things do not transfer between contexts. Range of motion may not do what you want it to do to a more contextual performance, whether that's athletic, whether it's simple activities of daily living, just in improving range of motion within a treatment with a manual therapy treatment and osteopathic manual treatment may not go back into the context of daily living or physical performance that is going to impact the person positively in the way they want. It very well may and oftentimes does, but there may be some context that we can identify where the treatment change in range of motion may not apply to the change in physical performance. So thank you for listening this far. Hopefully you've learned something, and we'll talk again soon.